Thank you very much, Katie, for that very nice introduction. Again, I am Larry Lindenbaum. I'm an anesthesiologist and critical care doc at the University of Minnesota, and I'm very pleased to be here with you today. Today, we're going to talk a little bit about a modern approach to neuromuscular monitoring, that being the use of quantitative monitors. Before I get started, I do want to make the usual set of disclosures. That includes I've done a speaking engagement with Blink as we're all here today, as well as I am on the Advisors Bureau for Vertex Pharmaceutical. Further, I should disclose that a couple of the images that I am using in this presentation were actually generated by AI because I can't draw very well myself. As far as objectives go, we have three major objectives here. That is, to address the clinical challenges that quantitative monitoring is designed to address, how EMG-based quantitative monitoring improves patient safety and reduces costs, and finally, why sugammadex alone is not enough to ensure these things, and how unmonitored dosing still leads to incomplete recovery in many patients. So how did we get here? Well, in 2023, the American Society of Anesthesiologists released some updated practice guidelines, as I'm sure you all are aware. These guidelines were very specific, and I'll get to them in a minute. But what was remarkable about it was the very same month, an entirely separate task force that was put together by the ESA also released their own findings, and the results were almost identical. And this occurred despite the fact that the two groups actually did not work together. Their final recommendation was that quantitative monitoring for neuromuscular blockade is mandatory. More specifically, what they outlined were five major points. Number one, as I already said, quantitative monitoring is mandatory. They recommend quantitative over any subjective or qualitative assessments to reduce the risk of residual neuromuscular blockade. And we'll talk a little bit about why that is in a bit. Number two, they said avoid clinical signs. They strongly recommended against using any clinical assessment alone, like head lift or hand grip, which are some of the things that I at least was trained on when I was an anesthesia resident, and I'm sure others of you out there were as well. Due to their profound insensitivity in actually detecting residual neuromuscular blockade. Number three, they clearly state that there is, in fact, a preferred monitoring site, and that preferred monitoring site is the adductor pollicis via the ulnar nerve. The reasons for this we'll go into specifically, but the short answer is, as it is one of the last muscles to recover, it provides one of the greatest degrees of safety when utilizing it as your yardstick. Fourth, they very clearly state that the extubation safety target is a train-to-4 ratio greater than or equal to 0.9 before extubation. And again, that data comes from measurements specifically on the adductor pollicis, which is part of the reason that that muscle group was actually chosen. Finally, the fifth item was very, very interesting because it's the first time that I can think of that they've actually come out with a preference for a medication of any sort. They specifically recommend sugammadex over neostigmine for deep, moderate, and shallow depths of blocks induced by rocuronium or vecuronium. Now, this is very unusual. Most people, I think, who were aware that work was being done in this space were expecting them to only recommend sugammadex for deep and certainly not for shallow. But because of the data, it is very clear that sugammadex really is the preferred medication in this particular space. So given these recommendations and the clearly outlined guidance, one would think this should be the end of the story. And yet, not so much. So what's the problem? The despite decades of awareness of residual neuromuscular blockade, it remains a major patient safety issue. Without any objective quantitative monitoring, up to 65% of patients may leave the operating room with residual neuromuscular blockade. This is not a minor complication. It's a significant patient safety crisis. Residual neuromuscular blockade, which is defined as a train-to-4 ratio of less than 0.9, is directly linked to an increased risk of postoperative pulmonary complications, upper airway obstruction and hypoxia, impaired swallowing and aspiration risks, as well as a prolonged PACU length of stay, which tumble down hill to a variety of other additional financial considerations. The real problem, though, is that we do not recognize many of the adverse or non-routine events in the PACU as being related to residual neuromuscular blockade. And what do I mean by that? Well, this is really a blind spot of ours. We think we're doing fine in this space. And in large part, it is all due to classic cognitive bias. If you ask your colleagues at work tomorrow, how many folks have seen any evidence of residual neuromuscular blockade, most would say they've never seen it. It's not a problem in their practice. A few who've been in practice for quite a long time may report seeing it, and some may say, well, I saw it when I was a resident, but that was probably because it was a resident that was taking care of the case, taking care of the patient, and they underdosed or didn't read the signs properly. The other point to the cognitive bias that really blinds us is that there's a total lack of feedback. We discharge our patients from the PACU, not really paying attention to necessarily how long they stayed, but we don't follow the patients to the floor or at home. So some of these patients go home and end up back in the operating room 2 days later with a pneumonia, or they go to the floor and end up re-intubated in 24 hours. Most of the time, we aren't aware of this. Frequently, these issues are attributed to some aspiration, which often gets bundled into, well, it happened sometime after the OR, but nobody goes back to truly tie it back into the fact that perhaps they weren't fully reversed in the PACU after all. The last issue is one that we always have: availability heuristics, or related to the recency effect, right? We remember the 99 cases that went smoothly, not the one that had a subtle delayed respiratory complication in the PACU. So where are we? Well, quantitative neuromuscular blocking monitors are a fundamental safety monitor. It is not just a new gadget that we get to play with. Its adoption in our practice is as critical as the other monitors that have created our modern standard of care, right? If you think about it, we would never accept clinical signs like, well, the patient looks pink as a surrogate for actually using a pulse ox, right? We would never accept the idea that, well, I can feel the bag moving as the patient is breathing, so clearly that's a good indication of some degree of end-tidal CO2, right? So if that's the case, why in the world would we accept simply watching the thumb in place of an actual quantitative train-to-4 ratio? The 2023 ASA guidelines have officially moved quantitative monitoring from a suggestion to the recommended standard of practice. But I think it's important to understand how we got here in the first place. Or rather, I think we need to understand what that means for us at this time. Number one, it clearly shows the standard is set. That is, a plaintiff's attorney no longer needs to prove monitoring is standard. The ASA has already done that for us. The ASA has come out, and the ESA have come out to say, this is what we believe is standard of care. So the burden of proof, therefore, is now reversed. This question is no longer, why did you monitor, doctor? The question is now, why didn't you monitor? And clinical judgment is no longer a defense. Relying on subjective signs when it is clear an objective recommended tool is available is no longer a defensible position. And but it's important to understand how we got to the idea that subjective signs were in fact okay. The train of four was introduced in the 70s, and our practice has long been constrained by visual assessment as the only good monitor. It's true that back in the 80s, some quantitative devices emerged, specifically the AMG, which stands for accelerometrography. But at the time of their release in the 80s, they were very flawed for a number of reasons. However, modern tech finally offers us a reliable, user-friendly tool to overcome those limitations, and the ASA and the ESA have finally recognized this and fully embraced it. However, it's important to recognize that for 55 years, basically, the only thing we had and what we learned was based on our visual assessments of the twitch counts and the observed fade and our clinical exams like head lift or hand squeeze. However, as with everything else in the practice of anesthesia in the last 50 years, we've scienced the hell out of this part too, and we have now made it safe. So what do I mean with respect to all of this? So why don't the clinical signs actually work? Well, studies have showed repeatedly that clinical tests like head lift and qualitative visual monitoring are completely unreliable. This stems from the fact that repeated research shows the human eye cannot detect fade reliably until the train of four ratio is below 0.4. Now, I don't know about you guys, but when I did my residency back in the early 90s, I was told this then. It still didn't stop us from trying to just use more clinical signs to say that the patient was reversed, but we've known this for a very long time. Even more specifically, 82% of patients with a train of four ratio of less than 0.9 can maintain a sustained head lift for greater than 5 seconds. And even more profoundly important is something that many people do not recognize. When an endotracheal tube is in place, respiratory parameters like respiratory rate, tidal volume, and end tidal CO2 truly are meaningless. And I'll get into that a little bit more with some specific data later in this discussion. The mandate by the ASA and the ESA of confirming a train of four ratio greater than or equal to 0.9 before extubation is a threshold that only quantitative monitoring can confirm. Now, I do want to diverge here for a moment to discuss some nuance regarding neuromuscular monitoring and blockade, and why there remains some belief that these monitors don't really work well, even the quantitative monitors. I'm going to start with what I think is the most common reason that people quote. This is the diaphragm paradox. I think everybody is familiar with this, right? You say the train of four is 0, and the surgeon says, but the diaphragm is moving. Or you say the train of four is 0, and you can see what looks like respiratory effort on your monitor. Every last one of us has seen this at least once. The clinical observation, or rather, this importantly to understand is not a failure of the monitor. This is a physiological phenomenon known as differential recovery. A patient may begin breathing or show diaphragmatic movement despite a train of four count of 0 on the adductor pollicis because of this differential recovery. Again, we measure on the adductor pollicis in part because it's a hell of a lot easier than trying to measure on the diaphragm, but also in part because we know that the adductor pollicis is much slower to recover than the diaphragm, and so gives us an added degree of safety. This differential recovery between these muscle groups can be attributed to 3 key factors, and we'll discuss them in a little bit more in a second. Number 1, the diaphragm's unique anatomy and physiology. Number 2, its resistance to neuromuscular blocking agents specifically. And 3, the limitations of train of four monitoring, which I've already sort of addressed. So understanding a little bit about muscle sensitivity. Again, muscle sensitivity varies. In a very through drawing, I tried to demonstrate here which muscles are fast to recover and which are slow to recover. Look at this. The fast to recover muscles are exactly the ones that we are hoping are recovered the strongest. But the problem is they start to show recovery well before they're very strong. So the muscles of the diaphragm, the muscles of the laryngeal adductor muscles, and the muscles of the face are all very quick to recover. Whereas the muscles of the hand, the muscles of the forearm, and the muscles of the feet are very slow to recover. Uh, and because of this, the hand measurement is the safest indicator for safe extubation. To go into this at a little more depth, and I apologize for bringing everybody traumatically back to medical school, but let's talk a little bit about the physiology at the neuromuscular junction, and specifically the diaphragm's physiologic advantage. It has a much higher density of acetylcholine receptors as well as greater blood flow compared to the adductor pollicis. Those two factors increase its neuromuscular safety factor, meaning it takes a higher concentration of neuromuscular blocking agent to block it. And because of the very robust blood flow, that neuromuscular blocking drug washes out faster as well. Further, and this is very critical to understand, is that the diaphragm and the laryngeal muscles have a greater quantal acetylcholine release at their neuromuscular junctions compared to peripheral muscles. That is to say, if you were to isolate a single acetylcholine receptor at the diaphragm versus versus at the adductor pollicis and stimulate that receptor with acetylcholine, the amount of acetylcholine and stimulate that receptor with the amount of acetylcholine that is released due to the receptor stimulation is considerably higher at the diaphragm than it is at the thumb. And again, very important point as to understand the diaphragm paradox. So a very quick side-by-side comparison, just to sort of sum up the last between the adductor pollicis and the diaphragm. Is the adductor pollicis is the slowest to recover, the diaphragm is the fastest. The adductor pollicis is the last to recover, giving us an additional safety margin to ensure that the diaphragm is fully recovered before we actually extubate patients. The adductor pollicis is the gold standard for assessing recovery from blockade and readiness for extubation, whereas the diaphragm reflects a deeper level of blockade, but its recovery is not a reliable indicator for safe extubation. It is also very difficult to assess recovery at the diaphragm by any meaningful measure, whereas the adductor pollicis lends itself to very simple measurement practices. So I think, though, it's also important to discuss some of the other myths that we have as to why merely watching what a patient does is sufficient in deciding when it is okay to extubate that patient. This is a very important point, I think. By and large, if you talk to people and ask them what they think about, how they classify, I should say, rocuronium as a neuromuscular blocking agent, the overwhelming majority of people will say it is a short-acting drug and that reversal is easy. The reality is that it has been shown over and over again that even after 120 minutes and no additional dosing beyond that given to the patient at intubation, 30% or more of patients remain paralyzed. That is a train-to-4 ratio of less than 0.9. And even more importantly, those same studies indicate 10% of the patients, even after 2 hours, have a train-to-4 ratio of less than 0.7. Considerably lower than the expected number for safe extubation. The graph on the right side of my screen, though, is what I want to draw your attention to. This is something that we did at the University of Minnesota, and I very much want to point out some important features to this. We took a look at roughly 400 cases in the PACU, or both in the PACU and in the OR, of patients that merely received an intubating dose of rocuronium, and we followed them with a quantitative monitor over the course of the case. So yes, some of these were cases that were in the OR for 6 or more hours and did not receive any additional rocuronium aside from that dose of 50 or 100 milligrams that was given at induction. This graph is extremely important. Look at the 2-hour mark. At the 2-hour mark, roughly 45% of our patients still had a train of 4 ratio of less than 0.9. And even more surprisingly, look at 6 hours. At 6 hours, we still have at least 3 patients that, at least 2 patients that have a train of 4 ratio of less than 0.9, and 1 with a train of 4 ratio of less than 0.7. In fact, it's less than 0.6 at 6 hours. That is not the hallmark of a short-acting drug, nor is it the hallmark of a drug that can easily be reversed. And I think that this is another piece that we truly need to embrace as absolute fact to help us get over the idea that we can rely on time or clinical signs alone to determine when a patient is safe to extubate. So again, to go back, the flaw of clinical signs is the sensitivity versus specificity problem. We know that sustained head lift being seen in 82% of patients with a train of 4 less than 0.9 tells us absolutely nothing. It tells us that it's really, really specific, but it is not at all sensitive. And in this case, we need a sensitive monitor to determine when it's safe to extubate our patients. And again, I want to reiterate that 80% of patients still have a train of 4 ratio of less than 0.7, but can still maintain a head lift for more than 5 seconds. And again, the idea that just because the diaphragm can move does not mean respiration by itself is a reliable measurement either. And I will go into that some more in a little bit. I want to re-stress the dangers of unmonitored reversal before we get to that, though. Bodle et al. Showed very clearly that while sugammadex is better, residual neuromuscular blockade still occurred. So what they basically did is they told people to reverse sugammadex based on the manufacturer's recommendations. And that set of recommendations resulted in 13 to 15% of patients requiring more than the recommended dose of sugammadex to achieve a train of 4 ratio of greater than 0.9, and that unmonitored sugammadex dosing based merely on the manufacturer's recommendations for how much sugammadex to use still resulted in a residual neuromuscular blockade incidence of up to 40%. And sure, 40% is better than 65%, but it certainly isn't safe. Now, the corollary to this, and something that they don't spend much time on in the paper, but I'm going to dig into a little bit here, is the fact that while 13 to 15% of their patients actually required more than the recommended dose of sugammadex, 85% required less. Keep that in mind. The last thing I want to talk about before we get into the different types of neuromuscular, quantitative neuromuscular monitors is, again, a brief indication, a brief description of how these monitors work. At their simplest, at the simplest, these monitors all initiate a stimulation. That is, they generate some sort of supramaximal electrical impulse to a known nerve. In our case, it's the ulnar nerve. That's the nerve that we are choosing to monitor. That's the nerve that has been most well studied. The monitor then measures some sort of response to that stimulation. Whether it is an electrical response or a physical response depends on the type of monitor it is. And then from that data, we generate what is called a train of 4 ratio. That is, we have the device deliver 4 supramaximal pulses in rapid succession. We measure the height of our dependent variable at that point, which is either the physical response to the muscle or the electrical response to the depolarization of the muscle, and we calculate the ratio of that height of the 4th twitch to the 1st twitch to determine our train of 4 ratio. So it's a very simple concept. These are the 3 or really 4 types of monitors that are available, and a very brief comparison we'll do here. Number 1 is the MMG, that is mechanomyography. The MMG is the gold standard. It is extremely accurate, but it is totally impractical to use. No one to date has managed to generate a small enough, easy enough use device to be used practically in the everyday OR. The second type, and I alluded to this type before as it came out in the 80s initially, is the AMG, or acceleromyography. This is very, very similar to the KMG, kinetomyography. The difference is what is specifically measured. The AMG and KMG both have a device that goes between the thumb and the forefinger, and it measures either the actual strength of the muscle contraction, or it measures a current induction in a piece of metal stressed between those 2 digits that changes based on the fact that the fingers, the thumb and finger come together. They are motion-based. They are both very highly prone to drift. They both regularly overestimate train of 4. And when I say they overestimate train of 4, you often need to record a train of 4 greater than 1, which you would think isn't possible. But you need to record a train of 4 greater than 1 to ensure that you have hit a train of 4 ratio greater than 0.9 with MMG. And importantly, it requires free movement of the thumb and forefinger. EMG, on the other hand, which stands for electromyography, and is my personal preferred way to do this, is a very highly accurate measurement that very closely reflects the same measurements with an MMG. They are extremely efficient. They are very easy to use by using a single array of electrodes. You can apply it to the thumb. You can apply it to the foot as options to measure. It is extremely robust in resisting artifact from other RF interference in the room, as well as Bovie monitoring. And probably more importantly, it is not at all dependent, it is not at all prone to any overestimation of the train of 4. But because it's monitoring the compound action potential of the muscle and not a physical motion, it means that there doesn't need to be free movement. This means that you can tuck the hand, you can tuck the foot. You don't need to see anything to know that the monitor is properly recording exactly what you need to know. And this is, again, a challenge that many people have. I regularly challenge my residents to stop looking at the patient's hand, even if it's not tucked, and instead to rely on the monitor. It's difficult for us to do that because most of us, grew up with the idea that we need to watch the twitch, but we do not with the EMG, which is one of the beautiful things about this device. So again, my case for why electromyography over any of the others: accuracy. It very closely monitors, very closely matches the MMG without the AMG and KMG issue of overestimation. Its reliance on an electrical signal makes it robust against signal drift and movement artifact, and critically, it does not require a free-moving thumb or free-moving big toe, allowing the monitoring even when the patient's arm is tucked. And I think that those are really the 3 biggest selling points for using EMG over AMG or KMG. All right, I'm going to change gears again. I want to show you a patient that I had in the OR not too long ago. So as you can see from this monitor, things look pretty good, right? I'll highlight things here that I really want you to point out, that I really want to point out to you. And that is, based on this monitor, you can see a respiratory rate of 23, a pretty regular rate as well as an end tidal CO2 of 43 with a SAT of 98%. And to show you exactly what my vent looked like at this point, this is what my vent was set to. My vent was on manual spontaneous ventilation with essentially no PEEP. It was showing a rate of, it varied from 23 to 26, a tidal volume which varied from 180 to 200, and a minute ventilation of 5.3. Again, tidal volume of 180 to 200, a minute ventilation of 5.3, and as you recall from the last slide, a 98% SpO2 on an FiO2 of 0.29. Overall, not bad for a patient under anesthesia who's breathing spontaneously, right? Right. Okay, so what is this patient's train of four count and ratio? Anyone want to take a minute to guess? I'll show you. This was my TwitchView. This patient has a train of four count of 0 with a post-tetanic count of 12. And I'll get into that post-tetanic count in just a minute because that is also very important for properly monitoring your patient. But I just showed you a patient who actually seemed to be breathing okay. But again, my point is to highlight why respiratory effort is completely unreliable in the paralyzed patient when an endotracheal tube is present, in part because of that differential recovery we already talked about. There was clearly here no recovery at the adductor pollicis. There was enough recovery to generate a little electrical impulse at the diaphragm, but not enough to safely extubate this patient. Okay, so this gets us into, and the post-tetanic count reminds me, so how do we use this monitor? If I'm claiming that this is a new monitor and that we all need to start using it, how do we actually use it? Well, monitoring is a process. It is not merely to be used for reversal. I don't know about you, but again, when I grew up with one of those little black boxes where we stimulated the hand or the face, God forbid, you know, we basically only did it at the end of the case, right? I mean, we didn't really check it. Maybe we checked it to redose our VEC or a pancuronium, but mostly we checked it at the end of the case, and if we saw 4 twitches, we were good. That's not the way a good monitor works. The full monitoring is a process. It has to be broken into 3 phases. To be effective, it must be integrated into those same 3 phases we break every case into. That is induction, where we establish a baseline and find a supermaximal current before paralysis. Now, I will get into this a little bit more because establishing a baseline is far less important with an EMG than it is with an AMG and KMG. It is, in fact, mandatory with an AMG and KMG. It is not actually mandatory with an EMG, and I'll discuss why. Phase 2 is maintenance. You use the maintenance phase and what you see on your monitor, which is automatically firing every few minutes and recording its data into the electronic medical record conveniently, so you don't have to record it all, to use that data to titrate the amount of neuromuscular blockade we're using. And then finally, at emergence, we use the monitor to objectively guide the reversal dose and confirm recovery to a train of 4 ratio of greater than or equal to 0.9. So again, phase 1 and 2, baseline and maintenance. We start the case by, before giving any relaxant, we place the sensor and establish a baseline. You can do this in 1 of 2 ways. You can either give the patient some propofol and then establish a baseline, or in my case, I never really do that. I actually start this before I even give the propofol to get a baseline reading, so I make sure that all my monitors are actually working. Now, I said you don't need to do a baseline reading for EMG. Why is that? The reason is, for EMG, you can set the the current impulse that the device uses. Whereas if you do a baseline, the device will figure out the stimulation current the lowest stimulation current it can use to get a reliable signal. You can always get a signal by turning it up as high as it goes, or virtually always get a signal for turning it up as high as it goes. There's always troubleshooting no matter what you look at. But with AMG and EMG, or with AMG and KMG, it is absolutely mandatory to do this baseline, in part because of that regular expected drift that you're going to get by the end of the case. But again, an EMG, ideally put it on, go ahead and get a baseline, and then do your induction. Phase 2 is maintenance. Don't just give more rock. Titrate to the number that you actually need. What am I talking about? You can see this nice, convenient trend plot that is available on the TwitchView. In this plot, you can see that the very first point, I've got a train-to-4 ratio of 1 with 4 equal twitches. I then gave an intubating dose of rocuronium, and I watched what happened. Over the next couple of minutes, the train-to-4 ratio dropped to 2, then to 1, where it remained at 1 for the next 10 or 15 minutes. When the surgeon told me that they were ready to incise, I gave another 5 or 10 milligrams of rocuronium to watch the twitch go away and the monitor go to auto post-tetanic count mode, where it now measures the number of post-tetanic count twitches, so you can very clearly monitor just how deep the block is, not merely say, well, I have 0 twitches. I then waited for the spontaneous recovery, which clearly began occurring over the next, again, 45 minutes. And the surgeon did not actually need any additional paralytic during that time, so I did not dose anymore until the end of the case, as we started seeing spontaneous recovery to 2 twitches. And finally, as I described before, for the recovery phase, I titrated in my reversal. But I want to mention the value of PTC again, that is post-tetanic count in the maintenance phase. The idea in the maintenance phase is that we optimize surgical conditions for whatever the surgeon happens to need. Most of us would agree that not every case needs as much relaxation. Not every surgeon needs as much relaxation. And while all surgeons demand they want no twitches, they don't even really understand what that means. The post-tetanic count, however, solves the problem of being able to provide repeatable, adequate exposure conditions for the surgeon at any given time. It provides it allows us, by giving us a PTC count, it allows us the ability to quantify how deep the block is. It provides the precision to keep the patient in a sweet spot. Post-tetanic count of 1 to 3 is usually where I strive for my robotic surgeries, to ensure that we've got a perfectly still field without excessive dosing. And this then also, because at this point, we're really only affecting additional relaxation at the diaphragm, we're preventing any additional bucking on the ventilator. It keeps the surgeons happy, and it provides it avoids any prolonged recovery, because I always know I'm at a position that is recoverable with my recovery drugs. And again, phase 3, which is probably the most critical of these steps, you do not use clinical signs. You do not use a standard dose of sugammadex. You guide the dose. You've got the monitor. Watch it. What we tell people in our ORs is titrate in a little bit of sugammadex. Don't start with 2 or 4 milligrams per kilo just because that's what the manufacturer says. Give them 50 milligrams. Give them 1 per kilo. See what happens. The drug begins working very, very quickly. Follow it by adding some more if you need, until you get a train-to-4 ratio of greater than or equal to 0.9. Once you have that recorded, then you know you are safe to extubate it, always, 100% of the time. So the 2-part goal of neuromuscular management using a quantitative monitor is 1, surgical optimization, like we just discussed. Use your auto PTC function to be able to titrate to a repeatable level of blockade that keeps the surgeon happy. And number 2, use your recovery mechanisms, use the information that the monitor is giving you as the patient recovers to ensure 100% OR recovery from neuromuscular blockade. Now, I'm going to switch. We've talked a lot about the monitors. I want to talk about a couple of other very, very important points, because you're going to say it's all well and good. Yeah, I want to do this, but it costs money, and I can't prove to my VPs that they need to spend the money on these devices just because the ASA says or the ESA says that they should. I want to show you something here. So there is, in fact, a financial argument to EMG and quantitative monitoring in general. This shows you what we did at our hospital. We took a look. We deployed TwitchView monitors throughout the ORs at one of our hospitals in 2022. We didn't give people instruction on how to use them. We didn't tell them what to do. We let them get comfortable using it. They were already using a lot of sugammadex at the time. We let them get comfortable using it until about a little over a year ago, where we started telling them, now we want them to actually verify that the train of 4 recovery is 0.9 and have that recorded automatically in our EMR before they extubate. At the same time, we convinced our pharmacy to do a trial with a new compounding pharmacy. And that is, instead of getting the sugammadex as only 200 milligram vials or 500 milligram vials, we had the compounding pharmacy split it up into 100 milligram syringes. So while they charge us about 60% of the cost of a 200 milligram vial for a 100 milligram syringe, it allowed, which in turn resulted in a slightly higher cost per milligram of sugammadex. It allowed us to tell it allowed us to stop wasting sugammadex. Because remember what I showed you on that Bodil study, that 85% of those patients actually needed less sugammadex? Well, we felt we might be able to capitalize on that. And so we went back, and after an additional year of monitoring the use of sugammadex and the recovery rates in the PACU, what we found is that despite the fact that we are now paying more per milligram of sugammadex than we were then, since we can limit it to 100 milligram syringes and 85% of our patients required less than the manufacturer recommended dose, we are on target to saving over $300,000 annually at just the one hospital. This year, we have actually now deployed TwitchView monitors at all the rest of our 8 or 9 facilities. And the cost savings from this one hospital alone was more than enough to cover the cost of deployment at the other 9 facilities. So this is a clear win. Our pharmacy is all over this. They cannot believe how much money we are saving. The other thing that we looked at is we started following all of our patients in the PACU to take a look at 2 things. Number one, what can we really see if we are recording a train of 4 ratio of greater than 0.9 at end case as residual neuromuscular blockade in the PACU, and does this have any effect on patient outcomes? Well, the first one's easier to show than the second, but I'll tell you what we did see. We took a look at all of our data over the course of several months. We monitored every patient coming out of the PACU that received any neuromuscular blocker and that received any reversal agent. What we found is twofold. Number one, 88% of our patients are correctly, or 88% of our providers are correctly recording a train of 4 ratio greater than 0.9 at the end of the case. We did not give them a protocol to follow, like Thillen did, where he demonstrated you could get down to a 0% residual neuromuscular blockade rate if you were to follow his specific protocol. We told people instead, just titrate in sugammadex until you see a 0.9, as opposed to Thillen, who followed standard dosing recommendations by the manufacturer. The result in our case was an astonishingly low 2.6% of residual neuromuscular blockade in our PACU. And of those patients, which there were only 3, all 3 of those patients actually had a train of 4 ratio of greater than 0.85 anyway. We are trying to determine why, since those patients did have a train of 4 ratio of 0.9 documented in the operating room, why they were 0.85 or so when they were in the PACU, but that is still under study. The other thing that we showed, and I think that this is another incredibly powerful piece of evidence, is that we compared the recovery time for patients in the PACU prior to teaching people how to properly reverse and use the quantitative monitors with the recovery time of patients in the PACU after we rolled out the idea that they need to practice in a fashion to record a train of 4 ratio greater than 0.9. We looked at the types of surgeries we were doing. We looked at the lengths of surgeries we were doing. We looked at the average ASA scores and found no substantial difference between the patients in 2022 and 2023 and the patients in this past year, 2025. What we did find is that these patients in 2025 are getting out of the PACU on average 6 to 7 minutes sooner. Now, 6 to 7 minutes may not sound like a lot, but most hospitals report that PACU time is somewhere between $13 and $21 a minute. Some report as high as $100 a minute. Overall, that amounts to another nearly $500,000 in savings in reduced PACU time when you figure that in for the system, for our system. So finally, why switch to EMG? Number 1, accuracy. No overestimation of the train of 4. You get what you expect. You see exactly what you expect to get. Number 2, it is reliable. No artifacts, no drift, no worry about RF interference or Bovie interference. You can use it with the limbs are tucked. You do not need to see the site at all in order to use this. Confidence. It gives you objective, reliable, repeatable data on every single patient. And safety. As I just showed you, in addition to what others have shown in the literature already, there's a proven risk reduction in using it. Quantitative monitoring is the only way that we have ever developed to absolutely prevent residual neuromuscular blockade in 100% of patients. The ESA and the ASA both say we should do it, and I agree. Thank you.